And I'll start introducing a bit the topic and our speakers. So I'm Vanessa Gorasso. I work in Cienzano in the health indicator unit of Cienzano, which is the Belgian Public Health Institute. And I have a particular interest for everything related to burden of disease. I'm also part of this European Burden of Disease Network, which was funded more or less in 2019. This started as a technical platform to integrate and strengthen capacity in the burden of disease assessment across Europe and beyond. And since 2019, we have grown quite a lot, and we have more than 370 members now that are part of the network, that are part of more than 40 countries around the globe. But we have a specific focus on Europe, of course, as the name of the network says it. So today we're going to have two speakers. They're going to talk about a very important topic, which is antimicrobial resistance. As just a bit of a context, when we talk about antimicrobial resistance, we often also talk about healthcare-associated infection, as the two are quite related. As you can see from the graph, they share quite a lot of disability-adjusted life years. And the estimation of the burden of this burden can be found in two big efforts. So one are the results from the ECDC, and the other one, it's the results and the work from HME and the global burden of disease. So today we have two speakers, Sebastian Haller from Robert Koch Institute in Germany, who is going to present the results or the work that has been done regarding antimicrobial resistance in Germany. And then Tomislav Meštrović from HME and the University North from Croatia, that is going to talk about more the global approach and of antimicrobial resistance estimation. So without further ado, I'll leave the floor to Sebastian. I'll stop sharing.
Thank you, Vanessa, for the kind introduction and the opportunity to present here. So I will start right away with the sort of a personal perspective on the burden of antimicrobial resistance in Germany. So as content, I would go through AMR, why burden estimation is challenging, then show a bit of incidence-based burden estimates that we worked on, then show in detail the project and burden of bloodstream infections for vancomycin-resistant Enterococcus and MRSA in Germany, and a project on the AMR burden in Germany with a comparison of GBD versus B-code results and an outlook of what we are planning to do. So what is antimicrobial resistance and why are we concerned about it? So we do have antimicrobial drugs that we need in a lot of treatments, also for chronic diseases. To make cancer treatment possible, we need antibiotics. And those are medicines that are active against infections caused by bacteria. Antibiotics, viruses, antivirals, and fungi, antifungals, and parasites. So often what we mean with AMR is antibiotic resistance, but we do say antimicrobial resistance, so we're not very distinct here. Resistance means when microorganisms survive exposure to antimicrobials that would normally kill them or stop growth. And there's an increasing problem due to the overuse of antimicrobials worldwide, so that this can lead to a situation where simple infections may become life-threatening. You all know this concept of the DALIs, where we look into the time where diseases cause a certain harm, and here indicated in red, or can cause earlier death. And then we can calculate years lived with disability and years life lost. The challenge is that, for instance, sepsis does occur in particular, as you all already said, in those that have an underlying disease already. And that we then do have to distinguish what are the years life lost by sepsis and what are the years life lost by the underlying disease. And this is a challenge. Only part of the years lived with disability and years life lost is attributable to the sepsis, and we have to be very precise here, so not to overestimate the burden. So we started also together with the ECDC colleagues on describing the burden of healthcare-associated infections. There's a lot of evidence available, and we did this for several nosocomial infections. Conducted 13 systematic reviews, and then calculated from the available literature the attributable mortality, morbidity, and the length of disease that was only due to those conditions. And I will show this example for an outcome tree for neonatal sepsis in preterm born babies. So preterm born babies do have an increased risk to stay long in hospital, do have an increased risk to die, unfortunately, and do have an increased risk of all sequelae that sepsis can cause too. So here, what we did was only calculate what is the added risk, the added transitional probability for neural impairment, for instance, due to sepsis. And we conducted an umbrella review with all available reviews that had been conducted previously, and calculated the risk differences, and could thereby distinguish the added risk only due to sepsis, as indicated here in those forest plots. And we had those available for each of those sequelae. So we can now impute our incidence of sepsis into such an outcome tree and be relatively sure that what comes out is only the risk attributable to sepsis. And the next step from there was to take this work on burden of healthcare-associated infections into calculating the burden due to resistant bacteria. And this was then mounted up to a high antibiotic resistance burden that was comparable for Europe to the piled up burden of influenza, tuberculosis, and HIV and AIDS. And that's the Cassini paper that was already mentioned too. So the tool, the BCode tool that was published, and it was possible to use it and make use of it. And we did so in several projects since, and now are working on comparing the vancomycin-resistant Enterococcus faecium and MRSA burden in Germany for a time span between 2015 and 22. With the objective to describe changes and identify potential risk groups for those two pathogens. So the data source that we use is our surveillance data, a lab-based surveillance system that we do have in Germany available. The R system, we have a coverage of approximately 30% of all hospitals in this time span. Now it's 50% today. And we have a data collection between 2015 and 22. And the case definition was that we used all blood culture positive isolates for VIE and MRSA for this calculation. And then we estimate the incidence per 100,000 inhabitants stratified to age groups. and gender, and then can use these to put them into the B-code tool to obtain DALYs and attributable deaths from the underlying outcome trees. So for VAE, we had 5,300 isolates available from 528 hospitals, and the incidence varied throughout the years between 1.4 and 2.5 per 100,000, and you also see the attributable death between up to around 500 in the highest year, 2021. And here you see in the graph the DALYs per 100,000, and in the line graph you see the incidence per 100,000 on the right side, the scale, and how it is distributed between YLL and YLDs. So it's in particular helpful to see that we do have in Germany certain age groups that are suffer from particular burden here of VAE. Male and older age groups are a target group where we could see on one hand why, and where we will conduct research, why are they under such a higher risk, and what can we do to prevent this burden and reduce it. The next pathogen, MRSA, in comparison, there we had a reduction throughout the years, coming down to a plateau now. And we can see that here, even older age groups of male are affected, and also the younger, the below 1 year old that suffer from a higher burden. So we identify different groups that should be targeted for prevention of infection, and where we will have to do a bit more research on one hand, and where we can strengthen our programs potentially to prevent this burden. So this work is very helpful. And then, as you said, the GBD work was available, and also with the VisHub data, that is with a great tool where we can see how the burden is in Germany due to sepsis and to resistance attributable death and resistance associated death can be compared. And our question was, how does this compare to our results, and how can we make use of this tool in a similar manner as we did with the B-code tool? So the one challenge is when we want to compare the estimates, that the questions that are posed, the study questions, are slightly different. So what is the burden of antimicrobial resistant bacteria is one question. What is the burden due to a specific group of drug pathogen combinations and certain infections is another question. And what is the burden only due to antimicrobial resistance and the lack of treatment options? And this is very roughly describing how those study questions may be attributed to both projects. And then there's another challenge for comparing the estimates, that we do have different drug pathogen combinations that the studies looked into. So the GBD study is much more comprehensive, with a more comprehensive approach in terms of the underlying infections, and in terms of the pathogen drug combinations that were used. So we've, together with the IHME colleagues, we discussed how to find the common share and how to stratify the GBD data to this. And we found 11 pathogen drug combinations that allow for comparison. I did this for Germany, and here you can see for those pathogen drug combinations a comparison where we find that the results for death here, and also for DALYs in the next graph, are very comparable, and the confidence or uncertainty intervals are overlapping. And this added a lot of confidence in the usability of the two data, and that the approaches both were valid, and that we came to similar results is somewhat surprising, I found, as we do have different observational periods, differing methodology underlying incomplete pathogen drug matching even after stratification, and differing study questions. But nonetheless, we do arrive with similar results, and this allows us to dive more deeply into working with the GBD results with an increased confidence. So we do have a project financed by WHO Hub and RKI in cooperation with IHME, with the aim to see whether we can make more use of the GBD data when analyzing country differences between neighboring countries, and to identify possible best practice examples or particular challenges and risk groups in particular countries. And this is how this looks like from a German perspective, Germany here in black, and we can distinguish between not age standardized and age standardized estimates from the GBD study here, and see how the burden in Germany is always higher for all those species than, for instance, in Switzerland. That's the public health institution where I would like to ask, what are you doing better in Denmark for some bacteria, and also in other countries. So we can make comparisons, for peer-to-peer comparisons, that are really helpful for our from our country public health institute perspective. So to summarize, we do have different methods that were used, and somewhat similar results. The total burden of associated and attributable mortality due to bacterial AMR in Germany was 45,000 deaths that were attributable and that were associated, and 9,600 that were attributable. Those are the GBD results then, and the largest fatal burden of AMR derives from bloodstream infections, followed by the respiratory and intra-abdominal infections. And making use of the GBD results and comparing those to what we have from our surveillance data now allows us also to compare the burden of AMR to chronic diseases and other diseases in Germany, which shows that AMR death are among the top 10 causes of death in Germany. And this is, this shows the importance of this work. And it also shows, though, that with both approaches, and I guess Tomislav will be more detailed on the GBD approach, we are able to distinguish between the underlying disease burden and the add-on burden of AMR and of the infections that are caused by antimicrobial resistant pathogens. So this is a group work. There are just several names on here. It's not a complete list of all those who work on this project, and I thank all of those who cooperate and help with this, as this takes a lot of work to derive with good estimates for the burden of disease of antimicrobial resistance in Germany. Thank you.
Thank you very much, Sebastian. Very complete overview. And indeed, it seems very difficult to calculate these estimates, and also very important to do that when you see the ranking with with the cause of mortality, it's quite yeah, an important comparison. I'll leave the questions. So people, if the attendees want to leave already questions in the chat, they can do that. But I'll leave the discussion for the end. So after the presentation of Tomislav. So Tomislav, the floor is yours.
Thank you so much for the virtual floor, and thanks, Sebastian, for the introduction. Introduced many important concepts. I hope you can hear me well, and I will share my screen. So do you all see my screen?
Yes. Thank you.
Perfect. Okay. So I will just make a short introduction to the grant project, especially the newest iteration of the grant project, which was just published a month and a half ago. I will go through some results. I will make a focus on European regions, so Western, Central, and Eastern European region, and make some policy recommendations that stem from this research. So how it all began in short. So the importance of the burden was highlighted by the O'Neill report in 2014, which estimated that up to 10 million deaths per year will be happening due to AMR if left unchecked. But this faced some criticism because there were no rigorous location-specific data. People criticized maybe overly simplified models, and we needed urgently maybe better estimates and evidence-driven studies to inform practical solutions. And basically these limitations spurred the, in a way, catalyzed this whole research endeavor, which we know today as a grant project. This was launched in 2017, and the publication was in 2022. For the year 2019, we saw Sebastian highlighted that study. But this study provided global and regional insights into the burden of AMR. This was basically done using the GBD methodology, but maybe in a different universe. You will see how, and we still aim to implement AMR estimates into the overall GBD focus, overall GBD enterprise. And the whole collaboration is between IHME and University of Washington and University of Oxford, and it's funded by, at least the newest iteration, by UK Department of Health and Social Care and the Wellcome Trust. And in a way, this is significant commitment to addressing AMR maybe as a global issue. And in this latest publication, we have contributors from 81 unique countries, in a way spanning all regions in the world. We have regions from high-income, we have high-income countries, we have low and middle-income countries, and basically involving these experts and this large number of experts from every corner of the globe. I think we want to emphasize that this is a global shared challenge, and we need a unified response. And this is why we try to be as inclusive as possible and to include as diverse infrastructures as possible to tackling these critical issues. And of course, this project offers, I would say, unmatched estimates so far, because now we have in the newest study, AMR health burden estimates over more than 30 years. We use the methods that were already peer-reviewed for the 2019 study. But now we have estimates to see how burden shifted through time. And to have accuracy and relevance, we also have a lot of newly collected data, which was very important in understanding the current trends. And we had corrections for standardization and comparability across different regions and data sets. So that's why we are confident that we have a comparable data set in the end. And when compared to a previous study, we also have a larger number of infectious syndrome, a broader scope. And maybe I would say a major innovative thing is a forward-looking perspective, because now we also forecast AMR burden up to 2050. These were made exactly to help policymakers and healthcare providers, but also global health organizations to prepare for potential future challenges and also to make targeted interventions. And basically in this study, we compiled more than 520 million individual records or isolates from more than 19,000 study location years. We see this as a robust foundation for estimating the burden. And these are a range of different sources. So we have mortality surveillance, we have hospital discharge records, we have mortality data with and without patient outcomes, pharmaceutical sales, antibiotic usage surveys, even published studies, which from scientific journals, which we made like reviews of that. And also data was gathered through various collaborations with pharmaceutical companies that run surveillance networks, diagnostic labs, even data from clinical trials. All of this was in our data well, and also representing a different healthcare settings. Especially, we tried to get as much as data possible from low and middle income countries. And each step of the estimation process, and you will see the steps, had unique data requirements. And maybe here, this slide, we want not only to show from where the data stem from, but also to show disparities in data contributions. And you see here that high-income countries provide a much larger volume of data points when compared to low and middle-income countries. And of course, high-income countries have more established healthcare systems. They have advanced data collection infrastructure. They have better surveillance capabilities. And conversely, low and middle-income countries have challenges like underdeveloped surveillance infrastructure, maybe reporting gaps. All of this then translates to fewer data contributions. And with this image, we also always try to invite more data from low and middle income countries, but we are also cognizant of the problems and difficulties they face due to these various challenges. So in the newest study, the estimation, as I mentioned, was between 1990 and 2021. And we estimated all age and age-specific deaths and disability-adjusted life years. And thanks Sebastian for explaining DALYs, what they mean. And out of 22 modeled infection syndromes by GBD, we estimated 11 of them, or more precisely, we estimated AMR in 11 of them. They are listed here, and we will mention them again when we will go through the results. We also estimated for 22 bacterial pathogens, 16 drug categories, or maybe some combination of drugs, where you, for example, have an inhibitor or something. And in total, this translates to 84 pathogen drug combinations that we think are relevant for this global, regional, and then in the end country endeavor. So basically, there are 4 broad steps. First, we used the envelope of sepsis, from which we distributed the burden to specific infectious syndromes, then distributed infectious syndrome burden to specific pathogen, and then specific pathogen burden to antibiotic resistant and susceptible deaths. And then we used 2 counterfactual scenarios, where we used either relative risk of death or extended length of stay, depends on whether we estimated death or DALYs as the end outcome. And these are, in Graham project was the first to introduce these 2 scenarios now for estimating the AMR burden. So associated and attributable burden. And we would say that attributable burden is that burden that is directly attributable to resistance, or where we can say that the resistant pathogen is a direct cause of death. And for example, if the infection was with the same pathogen that was susceptible to that drug, the patient would have survived. On the other hand, associated burden is when you had an infection with a resistant pathogen somewhere in the chain of death, and we cannot be certain whether the death was a result of this pathogen or of something else. But in any case, the pathogen might have complicated the situation or not, but we want to have the full scope. So you can maybe observe these 2 scenarios as 2 extremes of the confidence interval. So for attributable burden, we are certain this is directly due to resistance. And for associated burden, we look at it for something that may have or not be seen as a cause of death, but definitely we think it may have contributed. And in the newest paper, we also have 3 scenarios for forecasting the AMR burden in the future. And the reference scenario, we think about it as the most likely. So what would happen if we continue as it is, if we continue as today? So the second scenario is gram-negative drug scenario. What would happen if we increase the development of gram-negative antibiotics that target gram-negative pathogens? And the third one is better care. What would happen if not only we increase the development of antibiotics, but also the accessibility of current antibiotics, and also if we increase healthcare quality and healthcare exposure to most people that are in need, how many lives would we save? And these are the forecasted scenarios that were actually made like this to target policymakers and other influential figures. And Sebastian already mentioned, but there is a MicroVis tool that now also contains the newest results, where everybody can check them, and we invite every suggestion or criticism how to make it better. and everybody can download it and make them studies or make a comparative studies like we've seen in the work with Sebastian and us. So feel free to explore, and a lot of things that we'll present today in the results are actually stemming from the microvis tool. And start just with this comparison. So this is from the microvis tool. We see the whole envelope of sepsis and how many bacterial infections, regardless of whether they were susceptible or resistant, happened in 2019 and 2021, and how many of those were associated with AMR and how many of those were attributable to AMR. And here you can directly compare 2019 and 2021. Actually, we found a decline in AMR burden during the COVID-19 pandemic within the years that were captured in our study. So that was 2020 and 2021. And the relationship between COVID and AMR, I would say it's very intricate. There are many mechanisms that could explain what happened, but basically there was an increased usage of personal protective equipment, better hand hygiene, physical distancing. I think all of these factors, and of course, less healthcare procedures, less operations, all of these factors likely contributed to the temporal decrease in the transmission of resistant microorganisms and lower burden. And this is something that we already see while looking at the newer data that will be the backbone of future studies, that it's actually rebounding to previous numbers. So this fall was temporarily, but at least we know that we can be effective and achieve the fall in the burden of AMR. And this is also how, when we look and think about the policy procedures that we can introduce based on the results, this is something that we should be cognizant about. And here you can see that as well in accordance with different age groups, in accordance with different years. And you can see them first, what is visible here is the high increase of sepsis deaths in 2020 and 2021. And these are sepsis attributed to COVID-19. Because in GBD endeavor, sepsis is every outcome that is linked with end organ failure after the infection. So of course, COVID-19 also belongs to the sepsis here. And what is also interesting is when we look at the deaths attributable to and associated with AMR by age groups, and when we compare 1990 and 2021, we can see a huge shift. In 1990, there was a large number of deaths in the earliest age groups or in children and neonates, but now the shift is towards more all elder or older age groups, which is very, very evident in the results. And this is especially important. I will tackle this again, but especially important in current trends in demographics. Older population, more need for healthcare. And this is one of the prime drivers why we estimated and forecasted an increase in AMR burden in the future. And if we look in accordance with specific pathogens, first of all, when you look 5 years and older and younger than 5 years age groups, overall you can see the decreasing trend in younger than 5 years age group. And this is, of course, a huge contribution to infection control and prevention, better maternal care, and a lot of other factors that led to the decrease of the overall infection in this age group. And of course, then the burden of AMR in this age group decreases as well. But in the older population, 5 years and older, you see an increasing trend of AMR through the years, except for the 2 COVID years that we said was a small decrease. And when you look the breakdown in accordance with specific pathogens, you see some show an increase and some show a decrease during these years. And for example, Staph aureus shows an increase, but strep pneumo and resistant strep pneumo shows a decrease. And this is a huge contribution of the large vaccination programs, especially across low and middle income countries, that led to the decrease of strep pneumo. And this is also where lies the value of these kind of huge estimation endeavors. You can see how much huge policy efforts and huge public health efforts can have an influence on the decreasing or increasing of the AMR burden. So this is why in this paper we also pursued so-called Dasgupta decomposition to better understand the relative contributions of various factors to the overall change in deaths that are associated with AMR. And this is actually a 6-factor decomposition analysis, drawing from methods developed by Dasgupta and accounting for these factors that are shown here: population growth, population age structure, sepsis mortality rate, proportion of sepsis death associated with AMR syndromes, proportion of AMR syndrome deaths associated with AMR bacteria, and proportion of AMR bacteria deaths associated with resistance. And if we take into account population growth, and population that is getting older. And also if you take into account the number of infections overall that is decreasing on the global level, but taking everything into account, still the net change is an increase in AMR associated deaths. And maybe I will go back to this Dasgupta decomposition later when we'll show the results for Europe. But overall, what we can say, basically in 2021, there were approximately 1.1 million deaths attributable to AMR, 4.7 million deaths associated with AMR. And we estimate that AMR deaths will increase steadily in the coming decade based on the current trends. And by 2050, and based on the current trends, there would be 1.9 million annual deaths directly due to AMR that we project in the paper. And this is something to worry about, because we estimate, for example, in the period 1990 to 2021, a cumulative 36 million AMR attributable deaths. But in the forecasting period from 2025 to 2050, a cumulative 39 million additional AMR attributable deaths. So, and also these are attributable deaths. So associated deaths would be broader than more than 160 million deaths. And this is something that we predict would happen if remediation measures are not in place. And for example, these are some scenarios, how many cumulative deaths can we avert in millions if we, for example, have a better pipeline for drugs that target gram-negative pathogen, and this overall broad better care scenario. And this is something to discuss, how to approach these scenarios in the future, because we often have the question, okay, you have a better care scenario, but this means people will live longer and end up in hospital eventually, and then again, higher risk of getting the resistant pathogens. But this is also something where we seek improvement in the further iterations. But for now, what we can predict, for example, on a global level, we can save approximately 22 million deaths in this 25-year period just by adhering to the better care scenario, or 11 million deaths if we immediately increase the gram-negative pipeline, which will end up in some drugs in a 10-20-year period. And I'll just try to show some results in accordance with the regions. And for example, for Western Europe, and in line with what Sebastian showed, so leading syndrome for AMR-related deaths was bloodstream infections, followed by lower respiratory infections, followed by peritoneal and abdominal infections. And we will see this is comparable to other also European regions, unlike, for example, when we compare to some low and middle income countries like African regions, where, for example, lower respiratory infections tend to predominate. We see a different scenario in European countries. And when we look, that's both associated with and attributable to bacterial AMR. These are these two scenarios that we mentioned. Basically, people say, okay, but you have a flat line from 1990 to 2021. Nothing is changing, nothing is happening. But the thing is, and what we have to understand, is the overall burden of infection is decreasing, and the number of AMR-related deaths is flatlining, which means the proportion or percentage of AMR deaths in the overall burden of infection is rising. So this is something to understand and to think about. And then again, we can look at specific drug-bug combinations and see which one tend to have the highest burden. And for example, for Western Europe, those directly attributable to bacterial AMR are, for example, carbapenem-resistant Pseudomonas aeruginosa, methicillin-resistant Staph aureus. These are some that have a really, really high burden. And for those that's associated with bacterial AMR, highest burden is seen in E. coli resistant to beta-lactam and beta-lactamase inhibitors, aminopenicillin-resistant E. coli, and MRSA, methicillin-resistant Staph aureus, but also macrolide-resistant Staph aureus. And this is a trend that we also see in, for example, in the United States, a high number of macrolide-resistant Staph aureus associated with AMR burden. In Central Europe, the distribution of infectious syndrome is similar like in Western Europe. Bloodstream infections in the first place, lower respiratory infections on the second place, peritoneal and abdominal infections on the third place. And you can see quite comparable time trend of AMR, both associated and attributable to resistance. You can see also this flat line between 1990 and 2021, but percentage increase in AMR burden across all infections. And when we zone in into some specific bug-drug combinations for Central Europe, we can see for those attributable to AMR, we see a high burden of carbapenem-resistant Acinetobacter baumannii and carbapenem-resistant Pseudomonas aeruginosa, and high burden of MRSA. This high burden of MRSA is characteristic for many different regions. And when we look at that's associated with bacterial AMR, we see a high burden of aminopenicidin-resistant E. coli. Again, macrolide and methicillin-resistant Staph aureus is also a pathogen with a high burden. And for Eastern Europe, again, comparable distributions of infectious syndrome, bloodstream infections again dominate, followed by low respiratory infections and peritoneal and abdominal infections. A little bit more changes in the trend during the 1990 and 2021. And of course, we can argue, yeah, but the trend is slowly decreasing for deaths that are associated with AMR. But again, we have to look at it through the lens of the overall envelope of sepsis, which is decreasing, and then see how the fraction reacts in this envelope. And for the deaths attributable to bacterial AMR in Eastern Europe, we see a high burden of carbapenem-resistant Klebsiella pneumonia, and Acinetobacter baumannii and Pseudomonas aeruginosa. And again, MRSA is a high burden generator, whereas for deaths associated with bacterial AMR, we now see E. coli resistant to fluoroquinolones, E. coli resistant to aminopenicillins, E. coli resistant to trimethoprim sulfamethoxazole. So some combinations that we didn't see in the previous regions. And of course, this also relates to the prescription practice and defined daily doses of these drugs in these regions, which can be quite high for Eastern Europe for these drugs that we have mentioned. And oh, I'm sorry, this is something. Sorry. And this is something we always try to emphasize. Please help us to produce better estimates. We always fight with the scarcity of data, especially the most important data, which is microbiology data with outcome, or laboratory results that relate to outcomes such as death. And we also hope that these estimates will increase awareness about the necessity of surveillance and tracking the antimicrobial resistance, which will then translate to better data as well. And we often fight with heterogeneity in their interpretation guidelines, because some use UCAST, some use CLSI, and there is a need to crosswalk. There is a need to standardize these two. And this is also a huge process in the overall estimation endeavor. And what we want to achieve with all of this is some policy outcome. We try to package these AMR estimates in so-called policy briefs that we try to disseminate among, for example, ministries of health or other relevant players in the field of healthcare. And with that, we try to prompt concrete quantifiable steps to regulate and spark innovation in the antibiotic industry, to increase the infection prevention and control measures in countries that need them the most, but also to create awareness across relevant sectors and general public to insist on proper antibiotic usage. And I think the work of Sebastian, the work of us, the work of everybody who does burden of infection and AMR-Burden resulted in some concrete outcomes. And this is why the ANGA, for example, meeting highlighted AMR as a crucial public health threat. And I think in the coming years, we have to establish targets to follow using the exact same methodology, and to see whether any actions that we do can translate directly to the impact, to the lowering of the impact of the AMR-Burden. And this is not going away. So it's always important not only to estimate, but also to disseminate the results and to address the threat. And this is why I think Microbe offers a good hands-on experience, and I think everybody can use it. It's quite easy to use it. There are some tutorials also on the IHME website, and I welcome you all to contribute to this work, which will be increasingly relevant. And with that, I thank you for your attention, and of course, I'm open to any questions. Thank you.
Thank you very much, Tomislav. Yeah, a good call for action, I would say. So we have already quite a few questions in the chat. So I'll first start with the question from Rechte that I guess it's relevant for both of you. So Brecht is asking, what are your experiences with comparing AMR burden estimates to those of other causes? Because you showed mostly, Sebastian, that AMR can be on the pathway to death for other underlying causes. So how do you deal with this methodologically?
That is a challenge, obviously, and this is why it is challenging to incorporate it into the overall GBD study, or has been challenging, and this is why it is challenging for so from our country perspective. We do have a project where we try to understand the incidence of sepsis better and see how much share of the AMR burden is within the sepsis, and then how this compares to and sepsis then is easier like to compare to those other diseases, chronic diseases, and we have to discuss where the burden of chronic diseases may have been overestimated previously due to not taking into account the relevance of sepsis firsthand. That's the easier part, and then AMR burden in the second step. That's from my perspective.
Yes, I agree. I agree with Sebastian. I think it requires a very careful contextualization, how to put these tests into the context. And we try to compare after the first Graham study. We try to compare it between different causes of death, because we thought this will have a particular impact among policymakers. But then again, yeah, we come to the problem, what is directly attributable to, what is associated, which number to use. And this will require some further work. And also, like Sebastian said, about disentangling what is the true cause and final underlying cause of death for certain diseases. So I think this is something to especially concentrate in the future.
Yeah. And I guess also this distinction between associated and attributable, it's not really easy to digest for non-scientific audience and so on.
Yeah, this is what we struggle with also policy reports. How to show the difference, how to highlight the difference. And then we introduced also the overall sepsis, which complicates the image. So this is what we struggle to. We are currently developing these policy briefs. And these are the exact questions we struggle with. And should we show it among the other causes of death or not? Yeah. Because it's not directly comparable. So this is a struggle, yeah.
Yeah. Okay, thank you. So then there is a question directed to Sebastian. Do you see increased burden of diseases of VRE and MRSA compared to VSE and MSSA respectively? A lot of short. So I hope you got it.
That's a good question. So the challenge is that we sometimes do have, as Tomislav also showed, we have a change in the proportion of resistant bacteria causing sepsis, and this is and sometimes if we only focus on the resistant bacteria, then it the trend results are misleading. If we have an increase of sepsis overall, but a reduction, and that's what we have of an increase of Staphylococcus sepsis overall, or a steady state in Germany, and then we have a reduction of methicillin-resistant Staphylococcus aureus in the proportion, and we focus only on MRSA, then we see a downward trend, whereas the sepsis problem is still there. And that's why what I like about the B-code tool, it's we can connect it very closely to our EARSnet data, and this is very helpful as we submit as the European countries to our data to the ECDC and they are then displayed in the surveillance atlas. You can see how the time trends differ of the resistant pathogens and the non-resistant pathogens, and we can use those results for analyses directly. So it's the answer is it's a good point to look into, and we should not only look into the antibiotic resistant pathogens. It's good to look beyond. It's good to look into sepsis too. And that's what these data sets are extremely helpful, and the burden work is helpful for. And but it's a similar manner, I think, with the GBD study, why you need the estimation for sepsis, and no matter whether it's due to resistant pathogens or not. And then you need the direct look into the resistance problem. And the attributable part is of great importance, as this is a preventable, with the bundle measures, preventable share. And then there's a direct, we have to be precise with those distinctions.
Yeah, and if I may add, there is also in microvistal, there is a tab called pathogen. And for every year now, up to 2021, you can see how much of a share is a resistant burden due to this pathogen and how much is due to susceptible burden. I mean, the pathogen that is not resistant to this antimicrobial drug. So this is also derived from one of the modeling steps that I mentioned, where we estimate the burden of each pathogen in the effective syndrome. And then from the burden of that pathogen, we estimate the attributable and associated AMR burden. So yeah, actually in the microvistal, you have the burden overall of the pathogens, so both susceptible and resistant. And then you can zone in and zoom in into the burden of the resistant if you're more interested in that.
Okay. Thank you very much. Thank you, Anders, for your question. There is a question now from Ashim, directly to Tomislav. He's asking about the steep increase of sepsis related to COVID that you mentioned. Is it possible to distinguish viral sepsis and bacterial sepsis related to subsequent bacterial infection?
Yeah, actually, when we show these circles in the microvistal, we had the overall envelope of sepsis, and within it, we had the burden of bacterial infections, and we thought we look at these as the burden of bacterial sepsis. And in this overall burden of bacterial sepsis, then we estimate infectious syndromes, pathogens, and everything else. So actually, we do divide that, and I think in the supplemental methods of the newest study, you have the exact numbers for viral and bacterial sepsis.
Thank you. So there is another question for you, Tomislav, from Brecht, regarding the plan for of GBD. If the AMR estimates will be part of the core GBD estimates.
Yeah, there are ongoing discussions and plans to integrate AMR estimates more thoroughly to the overall GBD estimates. We need for that to improve the granularity of AMR attribution in causes of deaths and disability. We also need to solve this issue of what is exactly attributable, what is associated, what is underlying cause of that. This is something that is currently being worked on. But I think we need this. We need this because I think this will also help then these comparative analysis across all GBD causes that we really need, and to really highlight where AMR has a role and what is the interplay of AMR among all these causes of death.
Mm-hmm. Yeah, and I guess this also relates to the next question from Alicia, that is asking, when comparing AMR burden estimates to those of other causes, did you take into account competitive mortality? So, you know, when you need to really compare with all the other causes. So I don't know if you have some more insights on this.
Yeah, this competitive mortality was factored into the AMR burden estimates because we want to avoid over-attribution of deaths. And basically, this is where we tried to introduce this counterfactual modeling to answer this question. But I think with our estimates, we tried to be as conservative as possible to accurately reflect the AMR burden rather than to displace causes of death. So this is also an active field in the future as well.
And Sebastian, I don't know if you wanted to add something about the last question.
Well, I think this is what was done within the outcome trees to distinguish directly between the underlying risk of a hospitalized patient population that then has on top healthcare-associated infection. And this is also the basis of the approach of the B-code outcome trees to distinguish the competitive mortality by only making use of the attributable risk, or here the risk difference that comes from subtracting the added sepsis risk from that of the non-affected patient population. So that's just another approach in those outcome trees, but we come, as we could show, to rather similar results with these conservative estimations.
Okay, yeah, thank you. So I don't see any more questions in the chat. I don't know if maybe there are other people that would like to ask some questions, but thank you anyways so far for answering all the questions and all the presentations. Maybe just a question regarding policy, because you, Tomislav, mentioned it also a little bit, but so sometimes we talk about AMR in healthcare infection, so really in the hospital, but this could also be outside of a hospital, you know, like GPs giving too many antibiotics and these things. Do you have some ideas of, in terms of policies, if like there is a preference or like a better target for targeting more outside of the hospital or inside of the hospital, or both?
Yeah, I think we try to target both in hospital and outpatient population. I think in the future, we need to be more in the umbrella of One Health to target broader, even environmental and animal health. We try to do some comparative studies in animal AMR also, but this is still not in the horizon. That what we want to do in short term is to include more non-bacterial pathogens. So for example, fungal pathogens and viral pathogens, because Candida resistance is huge problem. HIV resistance is a huge problem. Malaria resistance is a huge problem. So I think if we want to account for the full burden of AMR, which is in line with the initial O'Neill report, that he wanted to see the impact of the full burden of AMR, I think the next step would be to include more pathogens that are non-bacterial.
Yeah, but actually a really good point about the One Health approach. I guess we need to also go towards that direction.
And that's our scope too, from the local public health, or the German Public Health Institute, that we want to tackle exactly this aspect to, as the exposure to antibiotics is a main driver, and that more than half of antibiotics are administered to livestock animals in Germany, and then as of that share that is administered to humans, we have about 80% in the ambulatory sector. And with increasing results from our genomic surveillance, we do find that likely this estimate that you showed, that 75% of the AMR burden is within the healthcare sector, that this is that we will come to different view when we take more recent scientific results into account, and then the share is much larger that is due to what is going on outside of the hospitals, and this is going to be an aspect that we have to tackle in this work in the future.
Yeah, other methodological issues, I guess. there. Okay, thank you very much for all the presentation, and thank you for the attendees to participate in the interesting questions and discussions. So keep up the good work and all the challenges in the AMR burden. And thank you, and you can look at our website to see other webinars coming up soon. Thank you. Bye. Have a nice day.
Thank you for the invitation.
Thank you.
Bye-bye.
Thanks a lot. Bye-bye.